of the video. Okay. So basically, they're trying to show what a 3D mammogram is. The breast is compressed between these two panels, and X-ray dose is provided, and it rotates. As you see, it's rotating. So we see it from different angles of the breast tissue. You see, it actually looks like you're reading a book, like you're turning over each and every page, and it gives us much more better diagnostic experience in dense breast, because you could see cancers which you could easily miss. So for example, here they're showing there are multiple things superimposed on each other. That's what you see in a 2D mammogram. Everything is superimposed. However, on a 3D, you could see each and every in a layer differently, separately. So and they are only like a few millimeters layer. So see, as you see, you can see each and every alphabet separately. You could see each and every mass, any suspicious finding clearly, distinctively. This is one of the images which shows the dense breast. This area is very dense, and it's very easy. It becomes much more easier to see through them once you have a 3D technique. So now they're talking about X-ray exposure. It's well within the safety limits. Some people are more concerned about X-ray radiation dose in 3D mammogram. However, it's equivalent to screen film mammogram, which used to be used all the time, like 10, 20 years ago. It's slightly more than 2D mammogram, but it's definitely within the limits as per MQSA guidelines. So yeah, we use that, and I really like the technique. We also do 3D mammogram guided biopsies, and there again, they give you an extra edge over regular 2D mammogram and just regular 2D mammogram and ultrasound. Okay, so this is another picture just showing how X-ray is shot in different directions on the breast, and we were able to acquire much more information in a 3D technique. This is one of the pictures of how 3D mammogram looks. So I'm going to talk a little bit about breast ultrasound also. If I see a younger woman, I don't want to radiate her if I don't need to. So I start first with ultrasound. If it's 20-something, 30-something women, I first start with ultrasound. If I see a finding, or if she's very symptomatic, then we proceed ahead to the mammogram. We also use as an adjunct to dense breast tissue, which we just talked about. Sometimes there are findings on the mammogram which are way better explained on the ultrasound, and that's when we add ultrasound to it. And we also do ultrasound guided biopsy. Another advantage of it is to look at the axillary region, which you cannot see on the mammogram. You can see the breast, but however the armpits, where the lymph nodes are very well seen on the ultrasound. We have, I use Hologic and Philips IU22 ultrasound machines. I love them. Hologic is excellent. Philips IU22 has great technique too. So I'm a big fan of these two. This is just a picture of how things look on the ultrasound. You see this very dark black oval structure. That's how cysts look like on the ultrasound. This is, however, a solid mass, but if you notice, it's very well circumscribed, very well delineated. This is how benign masses look on the ultrasound. A fibroadenoma, which is a benign breast mass, this is how they will appear. However, this is not bulking. This is irregular. This is causing posterior shadowing. This is taller than wider. This is invasive malignancy. This is invasive cancer. This we are going to biopsy. So this is how we do ultrasound guided biopsy. It's a real-time procedure. As I have ultrasound probe on patient's breast, I'm looking through them, and simultaneously I use the needle vacuum system to target the area which appears suspicious on the ultrasound. It is done under direct vision. It uses local anesthesia. Only time you feel pain is when I administer local anesthesia. It's a pinch and a burn. Thankfully, after that, the patient doesn't feel anything. It's a very quick 10 minutes procedure. It's like getting your ears pierced. I use Severo. There are multiple other needles available in the market. Again, this is how it looks like. This is just a pictorial depiction, but this is how it looks like. The needle inside the breast tissue. This is where the breast mass is, and I have the probe on patient's breast, and this is before firing the needle. This is me where I'm scanning the patient. This is like one of the masses we're seeing, and I'm doing a biopsy. Other type of biopsy is a 3D stereotactic guided biopsy. So I've told you about the ultrasound guided biopsy. If I don't see any finding on the ultrasound, however, patient has calcifications or some mass, which I see only on the mammogram, then we do a tomosynthesis guided biopsy. So mass seen only on the mammogram, 2D or 3D, not on the ultrasound. Only microcalcifications, which you cannot see on the ultrasound. I do vacuum assisted biopsy, and again, it's a very quick procedure. Here I have taken a few pictures and I was showing it to Liz and she thought it was pretty scary. I assure you it's not. It's a very quick 10 minutes procedure. Patient is sitting down, her breasts are between two paddles. This is one of the needle. I'm giving her local anesthesia. The skin gets totally numb. The needle is inside the breast tissue. And here we have the mammogram or 2D machine where we're seeing what's going on as the needle actually able to target the right area and we're able to vacuum it. And patients do not feel pain, however, they do feel a little pressure because the breast is kind of compressed between two paddles. So finally, I just want to go over ACR recommendations. ACR recommendation says a woman with no family history, no extra risk should undergo mammogram every year, once a year, after the age of 40. However, patients who are asymptomatic and are at increased risk of breast cancer, like they have any genetic syndrome, they have any mutation, should start early as 25. Women with more than 20% lifetime risk of breast cancer based on family history, early age of menarche, there are some models which can detect how much risk you have, and I'll talk about it. They either start at 25 or 10 years before her mother got a cancer. Like for example, patient comes to me and says, my mother got a cancer at the age of 40. When should I start breast cancer screening? At the age of 30, 10 years before. Or if she has any genetic syndrome, then 25, okay? Women with a history of chest radiation, like some there are patients who get lymphoma treatment in early childhood, they should start early. Or any radiation therapy due to any other reason. Any women who have high-risk lesion like atypical ductal hyperplasia, LCIS, these are some descriptive terms in pathology. Basically, high risk, earlier, asymptomatic, low risk, start at the age of 40. So these are some of the cancer risk assessment tools. I use Bailey model method. They basically ask you, what's your age? What's the age of menarche? How many kids you have? What's your family history? And then they come up with a number to tell you what's your lifetime risk of breast cancer. If your lifetime risk of breast cancer is more than 20%, you need more monitoring than the average person. They may also need MRIs. And so as women, as doctors, what we can do. Women age 40 or older should get annual screening. Women with dense breasts should get screening ultrasound as well as mammogram. And women who have higher breast cancer due to family history, ovarian cancer, or any other factors will need earlier screening. That's it. Thank you.